Hi, good evening. I'm Dr. Kim Lam. I am here to talk about fibroids this evening. I know that this talk was supposed to be given in person, so I appreciate everyone's flexibility and when we had to do the format change. So what I'll do is I'll go over the presentation first. If there are any questions during the presentation, please go ahead and feel free to paste them into the comment section, and I'll try to answer them all at the end, and hopefully we'll get through all of it. So if we get started here. So uterine fibroids, they are benign tumors. That is to say that they are non-cancerous masses. They grow from myocytes, meaning muscle cells in the uterus. They grow in the wall of the uterus. A woman can have one or many fibroids. The fibroids can be very small and grow over time. They can grow quickly. They can grow slowly. The variability in this is can be very interesting in terms of management. If you look to the photo there, is there any way actually that I can point at the pictures or no? No, that's okay. So if you see there is a fibroid that is at the very top of the uterus. It's labeled pedunculated fibroid. So that sort of means that the fibroid hangs around the outside of the uterus. It attaches to the uterus via a very small stalk. It's not actually within the muscle of the uterus. Then there are some that are growing all the way inside the uterus. So if you look inside the cavity, there's one that's actually called the submucosal fibroid. So there's one hanging on a stalk inside. So those are the two extremes in terms of location, and it can be anywhere between. So, you know, under the outer wrapping, just above the muscle, deeply embedded within the muscle, a little deeper and impinging into that inner layer, the submucosal layer. And depending on size and location, we can have a number of different symptoms. We'll kind of get to that in a minute. But I'm going to talk a little bit about risk factors. So these are the things that predispose a patient to growing fibroids. So race is one of the most obvious things that we see. Black women actually have a 2 to 3-fold increased risk of growing fibroids. Not only do they have an increased propensity for them, they also grow larger fibroids, they grow them earlier, and tend to be more symptomatic. Parity is another risk factor. This is indicates the number of pregnancies a woman has had, the number of deliveries in particular. There's a remodeling that happens after delivery that helps to actually clear some of those abnormal tissue cells and reduces the risk of fibroids. So, you know, one of the methods that you could deal with this is having 15 to 20 children in your lifetime, but that's not really what we do. So it's kind of a moot point by the end of it, and it's really just as an FYI. So obesity is another risk factor. It increases the risk of fibroid growth. Diet is something that we've started to talk about more and more recently. Specifically speaking, red meat increases the risk of fibroid growth, foods that have a higher glycemic index, and vitamin D deficiency. So this is kind of a newer thing here, so worth screening for as part of the annual exam. Alcohol use, heavy alcohol use in particular, increases the risk of fibroid growth, and there is a genetic link involved. There's a familial component, meaning it can run in families, and then age is another risk factor, and it's just to say that, you know, the older we are, the more likely we are to grow things, fibroids being one of those things. By our late 40s, about 70% of white women will have grown fibroids, and black women over 80% will have some fibroid there. It may be symptomatic, it might not be symptomatic. A couple of other things to comment on. High blood pressure actually also increases risk of fibroids, and there are some environmental exposures, such as from insecticides, that can increase that risk as well. Interestingly, smoking makes no difference. We used to think it actually decreased risk of fibroids, but you will never catch any of us recommending that you smoke to do that. Fat, carotenoids, and caffeine intake also do not affect growth of fibroids. So we were talking a little bit about symptoms. On this page, it's focused a lot on abnormal menstrual bleeding. So again, we talk about location. The fibroids that are kind of more toward the outside of the uterus, particularly the pedunculated ones, are less likely to cause bleeding issues. The ones that are closer to the inside are more likely to have bleeding issues. That abnormality can range from a little bit of spotting after sex, a little bit of spotting in between periods, to having catastrophically heavy periods to the point of needing blood transfusion and even threatening death. So in those patients, it's imperative to have treatment. Amongst the things that we screen for is a low blood count, or is known for iron deficiency anemia. We recommend iron supplementation, but you also need to stop the source of the bleeding by managing the fibroid. Pelvic pressure and pain are other common symptoms of fibroids. Pressure has to do more with the size of the fibroid. They can grow very large. It can make you feel very full. It can give you a sense, with very large fibroids, it can give you a sense that you're unable to even have a meal because the satiety sensors are triggered early. Pain can be more or less broken down into pain with the periods. You can also have pain outside of the periods, pain during intercourse. There can also be acute pain in women who have degeneration of fibroids. So that's to say that the fibroid has outgrown its blood supply and it's started to break down, and that can be a very painful process. Very rarely you can have pedunculated fibroids twist on its own blood supply, and that's called torsion, and that can cause acute pain as well. Amongst other symptoms, we also talk about compression. In the lower abdomen, you can have increased pressure with urination. You can have constipation, again having to do with size, the feeling of bloating. And in those cases, the only real way to manage those symptoms is to go ahead and remove the fibroid, unfortunately. Problems with fertility have a little bit more to do with whether they actually distort the cavity, meaning the inside of the uterus. So there's a certain lining, the endometrial lining, that is inside the uterus. If this lining is disturbed in some fashion, then it can cause abnormal blood flow, abnormal implantation. It can increase risk of miscarriages. It can interfere with fetal growth. Cause placental abruption, which means that the placenta could separate early from the uterine wall. It can cause preterm labor, and depending on how big and the shape and size of the uterus, it sometimes can cause fetuses to be malpresented, meaning instead of the baby being head down first, the baby could be butt down, and that may necessitate a cesarean delivery. So the way that fibroids are diagnosed are typically during an exam. So it might be routinely picked up during just a yearly physical. It could be picked up because there's some kind of pain that prompted us to order an exam that we feel it, or imaging where we can see it. So the picture on the side there shows kind of a darkened area. I know it's so hard to show where things are if I don't have a pointer, but along the back side of the uterus there's kind of like a dark round area, and that's the shadow of a large fibroid on the back of a uterus. The typical imaging that we would do for this is almost always a pelvic ultrasound. Sometimes we incidentally pick it up on MRIs for other reasons. So that's not the first thing that we do for fibroids, but someone could come in with back pain, they're seeing their orthopedic surgeon, they happen to see a big mass in their pelvic area, and they get referred for management of a fibroid. The saline-infused sonography means that we're doing an ultrasound. It's a special type of ultrasound where we infuse normal saline inside the uterus, and that helps to push the walls apart. And so if there's a fibroid inside the cavity, when the walls are pushed apart that way and we place the ultrasound in, we are able to see kind of a dark mass, just similar to this picture here. indicating a fibroid. Hysteroscopy is not, it's not an initial method of diagnosis. It's something that we are doing when we, for example, don't know what the cause of bleeding is. We have done these other studies already, and we go in and place a camera inside the uterus. It's typically done either in the office or in the operating room, where we can directly visualize inside the cavity, and sometimes we see fibroids at that point. So, is treatment necessary? Largely it isn't. A lot of women don't have any symptoms, and because these are benign, non-cancerous tumors, we don't recommend treatment if they aren't causing any trouble. So by trouble, again, we mean the heavy bleeding, the bleeding between periods. If the fibroid is growing rapidly and we're concerned that it will continue to grow at that rate, infertility, or if there's pelvic pain. So if there's some kind of benefit that we are to gain, that's when we recommend treatment. Otherwise, an asymptomatic fibroid, we often leave alone. Treatments, we have lots of different kinds of treatments. Medication is usually the first line that we offer because it's kind of the least invasive, the most reversible, birth control pills being probably the most famous, but anything with any kind of hormonal component can be used to manage fibroids, because fibroid tumors are hormone sensitive masses. They respond to hormones. So pills could be a method, an IUD could be a method, the depot shot, Nuva rings, virtually anything that we typically use for birth control can be useful, and sometimes progesterones we can use that are not in birth control form. Gonadotropin releasing hormone agonists is a different type of medication that we use to promote medical menopause, and again, because fibroids are hormone-sensitive structures, we sometimes, in certain instances, can give a medication that essentially shuts down your own natural hormone production and puts you into a medical menopause, and that can help with symptoms as well. Other treatments, there is something called a uterine artery embolization. This is typically done by a radiologist, an interventional radiologist. They place tiny coils in the blood that feeds the uterus, and it blocks blood flow to the uterus. Not completely, but with less blood flow, there's less there are fewer nutrients feeding the fibroids, so they start to shrink to some degree. MRI imaging guided focus ultrasound surgery, this is a new approach. There aren't very many people who actually do or use this method to destroy fibroid tissue, but it's non-invasive. There's no cutting on the abdomen involved, but they blast energy at the fibroid and get it to shrink down. Among the surgical treatments that are offered by a gynecologist, hysteroscopy is one of those methods again. So hearkening back to what we were talking about before, where we infuse saline inside the uterus to push the walls apart. We place the camera inside so that we can see. And when there is a fibroid there, we have special equipment that we can use to chew up that fibroid and suction it out as we dissect through it. So that is a minimally invasive method of removing a fibroid if it's sitting inside the cavity, or most of it is inside of the cavity. So it's not really appropriate for every type of fibroid. A myomectomy is a different conservative approach where we try to remove the fibroid without removing the uterus. This can be done laparoscopically. It can be done open, meaning through a C-section type of opening in the abdomen. The recovery is probably about 4 to 6 weeks, typically speaking. This is appropriate, especially for women who are pursuing pregnancies in the future. So this helps to preserve the ability to have children. And the sort of the last ditch method of treatment is removing the uterus. This does not mean that we necessarily remove the ovaries. We remove the uterus, which is the source of the fibroids. But obviously pregnancy is not possible afterward, and this is the final treatment. There are multiple ways of doing this as well, depending on size, shape of the uterus, past surgical history. We can do this vaginally, where there are no incisions in the abdomen. That's sort of my favorite way of doing it. We can do it laparoscopically as well, which is sort of my second favorite. And then the last is to do it open, again, through like an open cesarean type scar, where we have to open it all the way and remove the uterus. That way, that's typically reserved for very, very large uteri. And that typically solves the problem. So I know it's a short talk. I am very open to answering a number of questions. I think we have a few coming here. Thank you. How long does it take to recover after treatment? So depending on the kind of treatment, let's say if we're using medication, we expect even the first round of treatment to have some effect. Typically speaking, it can take 3 to 6 months to see what the steady state is, so to speak. So typically we give 3 months at least on birth control or progesterone treatments to try to see if there's any improvement. If we're talking about surgical recoveries, so a hysteroscopy where we're removing fibroids non-invasively just from the inside of the uterus, if that fibroid ultimately is the culprit in the bleeding, the improvement should be immediate. With myomectomies and hysterectomies, those recoveries in terms of symptoms is also immediate, but the recovery for myomectomies and hysterectomies are 4 to 6 weeks. Next question, if fibroids run in my family, should I plan to have children sooner? That is certainly a good consideration. It does depend on the extent of the fibroids, because fibroids are so common. Just because a patient has a family history of fibroids doesn't mean that you will necessarily have a problematic fibroid. So that's something that a question that can be fine-tuned with your practitioner. Is a hysterectomy the only effective treatment for fibroids? No, it's not. So everything that I mentioned is effective. It really depends, again, on size and shape of the fibroid. It depends on the person responding, because sometimes the medication treatments are not tolerated, not because they're not effective, but because of the side effects. How big can a fibroid get? Yes. We tend to size fibroids, comparing them to pregnancies. So, for example, if a fibroid is big enough to reach the belly button, we call it a 20-week size fibroid, because that's about how big a uterus is at 20 weeks. The largest fibroid I have taken out is 36-week sized fibroid. That is probably the biggest one I have had to take out. That was taken out through an open incision because there was just really no way to get around it otherwise. But they can get very, very large. My fibroids are outside the uterus and I am currently pregnant. If I remove them after delivery, how long do I wait before getting pregnant again? So a fibroid being on the outside of the uterus, if it's pedunculated, the wait time is probably shorter. Traditionally, we recommend 18 months between a myomectomy and pregnancy. But if it's really on a thin stalk, you might be able to get pregnant sooner. So that would depend again on the details of your anatomy. Are there any aging or skeletal changes to anticipate with a hysterectomy? Not if the ovaries are left intact. So skeletal changes, I'm assuming that you're talking about osteopenia or osteoporosis. And if the ovaries are removed, that's when those structures can be affected. If you're removing the uterus alone, there shouldn't be any change, or there isn't any change, at least initially. There's some suggestion that some women might go through menopause sooner rather than, the average age, but typically at the time that a hysterectomy is being decided, the symptoms are really damaging enough to lifestyle that it's typically worth it to that person. Okay, so what are the chances that my fibroids will come back after treatment? The recurrence rate of a fibroid is 50% after a myomectomy. So if we remove a fibroid but we leave the uterus intact, the recurrence rate is 50%, but not everyone within that 50% needs to have treatment or surgery again. So it's a smaller percentage from there, say about 20%. So that's that question. How will my fibroids and the treatment affect my fertility and sex life? So this is a two-part question. Fertility depends a little bit on location again. Those that are inside the uterus impinging on that lining, those are more problematic. Very small fibroids sometimes are not too troublesome. There are plenty of women who get pregnant spontaneously without help. There are people who are having trouble if there are already fertility issues, and as part of the evaluation we find that there is a fibroid. We may recommend removing the fibroid to try to increase the chances of a successful pregnancy, particularly if they're larger, at least over 3 centimeters. We tend to be a little bit more proactive in somebody with a history of infertility. With sex life, the treatments tend to make the sex life better, particularly if you're having very painful intercourse with the fibroid in place. So for women who are at that stage in their life are actually extremely happy after removal of the fibroid. So we can move on here. When is it time to talk to my physician about my symptoms? So if you wanted to quantify it specifically, abnormal bleeding, anything that is irregular in nature, so bleeding patterns of cycles that are less than 21 days apart, longer than 38 days apart, bleeding that is very heavy to the point where a woman is feeling dizzy, short of breath, those urgently need to be addressed. Women who are, if you're able to measure it because you're using a Diva cup or something similar to monitor the actual quantity of blood flow, so anything that's over 80 milliliters is something that we should start to pay attention to. Pain, anything that is causing a disruption in your normal activities. So if you're going to the bathroom more frequently, that's a change in your lifestyle that can be very unpalatable. If you have chronic pain and it's interfering with your ability to get through your day, go to work, it's requiring you to take medication on a regular basis, you're avoiding sex because it's so painful, any of these things that are interfering with normal daily living is worth talking to your physician about. What concerns should I be aware of during childbirth with a fibroid? With childbirth, the size and location matters again. So fibroids that are down by the cervix that are blocking the canal sometimes actually prohibit a woman from being able to have a vaginal birth. A fibroid that's kind of up and away a lot of times doesn't cause issues unless they're very large. A fibroid can cause contractility issues, meaning it can cause the uterus to be unable to properly contract down to its normal size after delivery, and that predisposes the patient to increased postpartum hemorrhage. And actually that's also implicated as to the reason why women have abnormal bleeding in the first place. So women who are having heavy bleeding because of fibroids who are not pregnant, that contractility issue applies in that situation as well. The other issue is, if the placenta is attached over the fibroids, sometimes that can cause some attachment issues. The placenta can start to eat and grow kind of tentacles into the muscle of the uterus and make it more difficult to remove. So that's one of the big risk factors for postpartum hemorrhage as well. It's not very common, but that's something to think about. And if a woman has actually had surgery for a fibroid in the past, that leaves scarring on the uterus, and if the placenta attaches over that scar, that can cause the same issue where the placenta attaches abnormally to the uterine muscle and makes it very difficult to remove, and sometimes can lead to catastrophic bleeding, even requiring a hysterectomy at the time of birth. But that's also very rare. Do fibroids ever turn into cancer? Not necessarily. Fibroids, for the most part, are benign tumors, but there are things that look like fibroids. So a sarcoma is what those are called, and those are typically about 3 to 7 in 100,000. So they're really not very common. It's recommended that we almost presume that it is a benign tumor unless there are other issues occurring, unwanted weight loss, night sweats. There are other symptoms that would make us more suspicious, bleeding that isn't controlled with medication, for example. So they can be more difficult to tell apart, but that is something to, again, discuss with your physician. Additional studies may be required in that circumstance. So we have a few more questions here. Do certain diet types, food groups help with fibroid prevention? Yes, the foods that are actually healthy, so high amounts of fruits and green vegetables actually reduce fibroid growth, and avoiding red meat is actually helpful for fibroids. So that's that. Why do fibroids cause heavy bleeding? Are the fibroids bleeding in there? The fibroids themselves aren't bleeding. It's the abnormal bleeding because of the local changes in the muscle and the endometrial lining. So because there's a physical disruption to the way that the tissue works on a normal basis, the contractility, for example, during periods, it's not able to contract down and clamp on the blood vessels that are in the muscle, and so those blood vessels continue to release blood. And so that's an abnormal change that's occurred because of a physical alteration. Let me see what else. Okay, so I have fibroids and have been to the ER several times for severe abdominal pain that ended up being fibroids. At what point should someone in the late 20s consider more advanced treatment? I would say that anyone who's been to the ER any number of times for severe pain should consider treatment. And if you're in your late 20s, the myomectomy might be something for you to talk to your doctor about, because that doesn't prevent you from being able to have children if that's what you want to do. Okay. Why does bleeding between periods happen? This is sort of the same, kind of the same answer as the previous, the abnormal contractility, the abnormal blood flow. And then what is the root cause of fibroids? This can get to be a very long answer, but the short answer I can give about this is that they grow from myocytes. Myocytes means a muscle cell in the uterus. The uterus is made of smooth muscle, and one of those myocytes can become abnormal through a mutation, and that abnormal myocyte can continue to proliferate and copy itself until there are many copies, along with some abnormal changes to local tissue, fibrosis, for example. So it grows into this kind of single cell originated tumor that can become calcified, that can become degenerated, but it's growing from one cell that has mutated, essentially. Maybe that was not as short of an answer as I meant. Any other questions? Nothing else? So I think that concludes the talk for today. I hope that you guys got something out of this. I'm happy to take questions in our clinic. You know, we have lots of providers all over Orange County, so you know, bring these questions up to your provider if you have any concerns. And otherwise, have a